Dr. Shen, I just want to thank you so much for taking the time to come back from the previous program of the report back from the San Antonio Breast Cancer Conference to answer just a few more questions that our attendees had for you.
Happy to. So glad to be back. And yeah, as I said last time, I think the question and answer is the most fun part. So happy
Exactly.
to
And
be
so
here.
these seem to be like the top questions that I was seeing over and over coming through via the chat
Hmm.
and live. And so we'll start with the first one.
Sure.
Is there any data on those early stage breast cancer patients that end, taking AIs at 1 year as opposed to 5 years with, that chance of recurrence? Is age factored into this? Is an AI effective even after 15 years?
Yeah, it's a great question. I think the overall question is what is the right duration of treatment? And it's very individualized as much as possible. We know that it's hard to get people to even the 5-year mark of aromatase inhibitors. There's a lot of side effects, some of which are menopausal in nature, but a lot of the joint symptoms and the bone thinning can be a major issue over several years. So actually about 25% of women aren't able to adhere to their prescribed course. That's quite a lot. That's a quarter of women, right? To
And I
even
fall in, I
5 years.
fall into that category, and I remember hearing that percentage, and I was like, where did that come from?
Yeah, so it's pretty high. We do have data that taking it for only 1 year is not as good as taking it for 5 years.
Mm.
It's more effective for the longer time period. But there have also been large studies looking at even longer, like 10 years, and it turns out that for most women, 7 to 8 years is enough. It doesn't seem like 10 years is necessarily better than 7 to 8 for most women. Of course, this is very different for each person. And I wouldn't want that to be kind of like a blanket recommendation. It's definitely like an individualized conversation with your oncologist. But it does seem like most women can do the 7 to 8 year range. Some people do get benefit from that extension to 10 years, but 5 years still remains the minimum that we're recommending because there is benefit over less time than that. 15 years, I don't think is a meaningful amount of time to keep going. That's a really long time to be on an aromatase inhibitor. And I think at that point, really the bone thinning can be a real problem. We do know that even after discontinuing after the recommended amount of time, that benefit actually is still protective, even in the 15 to 20-year range. So it still gives you some protection having taken it for that amount of time. But I think 15 years is too much.
And is age factored into this? Because I think about like those
Yeah.
in the AYA, adolescent and young adult range who were diagnosed under
Hmm.
40. And then I think
Hmm.
about those who were diagnosed maybe at the older end of the scale, say like in their 70s or 80s. Does that make
Right.
sense?
Absolutely. And I think, the big studies that have looked at these questions, age is accounted for and adjusted for. But that being said, I think, on an individual level, like with between an oncologist and their patient, age does play a big part in that conversation, right? I have a very different conversation with someone who is 80 years old and is struggling with arthritis already, right? Who may have osteopenia or osteoporosis and needs treatment for that, and then may have a low risk breast cancer. I definitely favor a shorter course. So it's very individualized as a conversation, but kind of overall in the studies, age was accounted for.
Ooh, it's a lot right there, but thank you so much. So our next question is, can ctDNA be used to monitor for mutations such as ESR1 to enable switching drugs in a timelier manner? Oh my God, I can't talk. Such as fulvestrant in ESR1 to, hmm,
Palacestrant,
yes,
yes.
fulvestrant. I can't say these words.
This is really a question more in the metastatic setting currently. I think there's still a lot to be learned from how to use ctDNA in the most helpful manner in the early stage setting. But definitely in the metastatic hormone receptor positive setting, there is a role for using ctDNA for monitoring for development of that ESR1 mutation. It's important to, after some time of exposure to aromatase inhibitors, that's where the ESR1 resistance mutation can develop. And so by kind of checking ctDNA upon progression or, kind of serially, detecting that mutation earlier can prompt a switch. And we have clinical trial data to support that. Either from an aromatase inhibitor to fulvestrant, or now we have an FDA approval for the new drug elacestrant, which targets ESR1 mutations. There's also several clinical trials that are testing that switch strategy as well. For example, the ELAINE-3 trial is testing if an ESR1 mutation develops on an aromatase inhibitor, switching over to a new drug called lasofoxifene. So, and it's just one of several trials testing that strategy. So absolutely there's a role. Now, in the early stage setting, someone who's taking aromatase inhibitor for, let's say, year, 4 out of 7, for example, this is the place where we have not yet figured out if it's meaningful to serially monitor for those ESR1 mutations, mostly because we don't know the right escalation strategy. Drugs like elacestrant are not approved for use in early stage disease. So we don't really have kind of an outcome or a change in our management as a result of monitoring for that mutation. Um, so it has not been incorporated into clinical care yet in the early stage setting.
Okay. Moving on to our next, what is new on the ER/PR positive, HER2 negative treatment front? Is it still preferable to treat HR positive cancers with targeted hormonal combos? Any new treatment changes for lobular?
Yeah, great questions. So I think two main developments coming out of San Antonio, and then kind of overall in the field, I can talk about a little bit more as well. The two things to come out of San Antonio were, one, we heard data for ribociclib, also known as Kisqali is the brand name.
Yep.
So currently for our high risk women, meaning those women who had lymph nodes, several lymph nodes involved, and perhaps some high risk tumor features as well, like a big primary tumor or something called grade 3, meaning that the cells look disorganized under the microscope. Those are women who can get currently Verzenio, which is the generic name is abemaciclib, for 2 years. That's alongside their endocrine therapy, their aromatase inhibitor, for example. So the Verzenio is given for 2 years and then it's stopped while the other one continues, the aromatase inhibitor continues. And that reduces the risks of recurrence. Well, so at ASCO last year and at San Antonio, we heard some more of the data for Kisqali, which is a similar sister drug. They're both have a lot of robust data in the metastatic setting. They're now being kind of brought forward into the early stage setting. And the clinical trial that studied Kisqali enrolled a slightly different patient population. They actually did not necessarily require that lymph nodes had to be involved because we know that there are other tumor features that can be high risk, even though it hasn't spread yet to the lymph nodes. So they allowed for larger tumors without any lymph nodes, or even smaller tumors with high genomic scores like Oncotype scores, for example. And they also found a significant benefit, but we're still waiting on more longer term follow up data, and we have to wait to see what the FDA thinks of those data. So it's not FDA approved yet. Currently, only Verzenio is FDA approved. But that's one big development that we can look forward to in the kind of near future. The other one is I talked about a little bit in the update is the addition of immunotherapy to chemotherapy prior to surgery. For those women who need downstaging of their tumor, who can't go for lumpectomy, for example, or have tumors that are unresectable at the beginning and need to get something to downstage, the addition of immunotherapy to chemotherapy does seem to improve the rates of getting all of the cancer by the time of surgery. That's called pathologic complete response. But it remains to be seen if that really does translate into preventing recurrences as well, which is kind of the more important endpoint. And we do not have those data yet. So these are early data. We're going to have to still wait to see if that will become a meaningful part of treatment. Things that didn't come out of San Antonio that I would say overall in the field, we've been using tamoxifen and these aromatase inhibitors for decades. But there are new drugs coming and being studied in clinical trials. There are essentially pill versions of fulvestrant. So it's a class of drugs called selective estrogen receptor degraders. Those are being studied now in the early stage setting. So instead of taking an aromatase inhibitor, or perhaps taking an aromatase inhibitor for some time, but then either staying on it versus switching to one of these newer drugs. So these are being developed, and we will probably need to wait several years to see those come to market. But that's kind of what's happening in the background. Nothing specific for lobular to come out of San Antonio. I do think lobular breast cancers are often kind of just like grouped in with ductal breast cancers in all these clinical trials. We enroll, women with either one, but lobular breast cancer comprises that smaller proportion, only 10 to 15% of breast cancers. And so I think this is a space where we can and need to do better and focus on that patient population to understand, because it is a little bit different biology.
It
So there's a
is.
lot that can be done there, but no major updates recently.
As a 7-year invasive lobular survivor, I definitely concur with that.
Yep, yep.
Um, so does immunotherapy without presence of the original tumor increase the risk of autoimmune issues?
This is a great question. So I think this is a follow-up question to a little bit of what I had talked about in some of the data from the triple negative breast cancer space, which is that it seems like immunotherapy is really important to add in for those higher risk women before and after surgery. Whereas the studies that have only added in after surgery when the main tumor is gone, it seems to be less useful. And we think that's because chemotherapy alongside immunotherapy is synergistic in a way. It's the chemo killing the cancer that then kind of causes inflammation and prompts that immunotherapy to work in the right way. Whereas
Mm.
once the whole tumor has been removed, immunotherapy doesn't seem to add much benefit. So this is a really great question. I think the um, issue here is not necessarily that immunotherapy without the original tumor actually increases the autoimmune side effects risk itself. It just means that there's not as much benefit. So, really, what you're getting is just the risk. Does that
Okay.
make sense? So, it's not necessarily that the risk is increased by there not being tumor, but there's no benefit. So, why would we do it then if we're
Right,
just giving the risk of that
right.
autoimmune disease? Absolutely.
No, that makes sense.
Hmm.
So this one, it seems that quite a few oncologists are missing the mark and not addressing potential issues like a lowered libido or no libido. What can the medical community do better to address discussions around our sex lives early on, whether you're stage 0 or you have, invasive types? What, how can that conversation start sooner?
I completely agree. And I think that this is really an area where we do need to do better. You know, a lot of these hormonal therapies, so particularly for our hormone receptor positive women who are going on aromatase inhibitors, who are going on tamoxifen, the side effects, this can factor into what I was talking about before, that quarter of women who can't take the fully prescribed course, right? And it's different for each woman what side effects she is experiencing, but certainly these therapies can contribute to sexual dysfunction, decreased libido, etc. I do think that this is something that's important to talk about early on and intervene early, because if it's kind of something that the patient may not want to bring up or may not feel comfortable talking about, but then kind of suffers in silence, that may lead to that discontinuation of a medication that we know is helpful and important for their cancer, right? I
Right.
don't have a good answer to this other than I think that we need to have more of these open conversations. And there's a lot of research in this field, and I think if patients are able to get connected early on to like a sexual health service, or for example at Memorial Sloan Kettering we have like a young women's program, although I know this is not just an issue for young women, but getting people connected to the right resources, to their OBGYN, to have these conversations early, to talk about non-hormonal strategies, lubricants, that sort of thing, I think is really, really important.
I agree. It's like understanding the options, but it can feel uncomfortable. And, I
I
can
bet.
speak to like the idea of my libido was not on my mind when I first got diagnosed. And
Hmm.
so, it's like, oh my God, just get it out, the cancer out. We'll think later. And I think this question is kind of like, thinking of it holistically of our quality
Right.
of life. Like, yes, we've got to get the cancer out, treat it and everything, but we also need to think of what happens once we say you are, no evidence of disease.
Exactly.
Yeah. And our final question, with HER2 positive treatment, is it completely gone or is there a risk of it reappearing? Does it require additional treatment?
Yeah, I think this question, I'm not sure exactly what it's getting at. So let me try to answer it and see if you think that this is what the person was asking.
Mhm.
So with HER2 positive treatment for nodal involvement or for tumors bigger than 2 centimeters, we generally give preoperative treatment. So chemotherapy alongside anti-HER2 therapy. Then at the time of surgery, we see how much disease is left. Did
Mhm.
we get it all? If so, that's a good sign. And we continue with just the anti-HER2 therapies after surgery. If we did not, that's okay, but that means that we need to step up the treatment or escalate post-surgery, right? So that's when we give a drug called Kadcyla to finish out a year of therapy. That's what we do for HER2 positive disease. Um, so the question of is it completely gone? Well, at the time of surgery, we resect everything. The surgeons take everything out. So then there's no sign, no visual sign of cancer afterward, right? So it's completely gone in that sense.
Mhm.
But what we're really aimed at treating with all of these systemic therapies, these IV therapies, is eradicating the seeds or the cells that could be circulating, not just what's in the breast, right? But those cells that could be in the bloodstream hiding out that can cause a problem years later. In other words,
Mhm.
a recurrence,
Right.
right? So that's what we're really preoccupied with there. So in terms of post all that pre I used post and pre in the same sentence. After all of that pre-surgical treatment and after the time of surgery, there is no evidence of disease, like you were saying. But because in some cases, if we don't eradicate all the cancer that was in the breast mass or in the lymph nodes, then we assume that we haven't eradicated all the circulating cells either. And that's why we step up therapy. It's for those circulating cells that we cannot see with our eye. So, yes, there still is a risk of it reappearing. There still is a risk of it reappearing even in women in whom we do eradicate everything,
Right.
although that risk is lower. But we recently at San Antonio did hear long-term follow-up data from that study that compared Kisqali to just a standard anti-HER2 therapy post-surgery, which
Mhm.
was Herceptin. And after long-term follow-up, there still is that significant benefit to Kadcyla for those women in whom we did not get all of the cancer. So there is a risk of things reappearing, but we're trying to minimize that risk by kind of matching what happened at the time of surgery, matching that aggressiveness of the
Mhm.
cancer because it didn't get eradicated with more aggressive treatment to try to reduce that risk as much as possible.
And I think, with everyone in the early stage, that is what we want. Like, we want to minimize that risk as much
Absolutely.
as possible to hopefully prevent recurrence.
Right.
Well,
While living a good quality of
well,
life, right?
exactly. While our quality of life is there.
Exactly.
But Dr. Shen, I just want to say thank you so, so much for taking the time to answer these additional questions. I think they were really needed, and I wanted to make sure that they were addressed. So just again, we really appreciate your time and willingness to come back and talk with us a bit more.
Of course. Thank you so much for having me.
Okay. Uh,